Very good evening, guys. Welcome to the platform of Dr. Banu sir's YouTube channel. Very good evening. So today we are going to discuss gynecology. So today I have planned to complete everything in gynec, but I am oncology. I'll be trying to take one more session, and I made a beautiful PDF and I simplified every topic in a crisp manner so that you quickly revise all the topics now in this session. So again, this session will be 2 hours. Again, this session will be 2 hours where I'll be touching all gynecology topics in a crisp manner. And yes, as I promised yesterday also, I've sent you the PDF. Today also, post class, I'll send you the PDF. So just before exam, if you can go through this PDF, that's more than enough. So I'm going to touch your brain with all the topics of the gynecology in a crisp manner. So that will be the advantage of this session. So let us start the session. Let's hurry up and start the session. So first topic I'm going to start is the embryology, right? So first, to start with, we have bipotential gonads. That is, the gonad is neither it's not decided whether it's going to be testis or ovary, right? So we have bipotential gonad at 5 weeks. So SRY gene, what is the, so last tiny CT they got a question, so we can always get this question again in FMG, ki what is the deciding factor for this bipotential gonads? So the deciding factor for the bipotential gonads is SRY gene located on short arm of Y chromosome. So it is the SRY gene located on short arm of Y chromosome. If this SRY gene located on short arm of Y chromosome is positive, then it will form testis. If it is negative, then it will form ovary. Right? Very good evening. So Rahul, I'll send the PDF post class in my Telegram group, or you can also take it in from the Banu sir's Telegram group, right? Banu Prakash sir's Telegram group. So if SRY gene is located on short arm of Y chromosome, if it is positive, then it will form testis. If it is negative, then it will form ovary. So again, in testis, you have two types of cells, Leydig cells and Sertoli cells. This Leydig cells secrete testosterone. And whereas Sertoli cells secrete anti-Mullerian hormone. Now, what is the function of the testosterone? Testosterone helps in the growth of the Wolffian duct. So this Wolffian duct gives rise to male internal genitalia, that is seminal vesicles, epididymis, ejaculatory duct and vas deferens. Whereas AMH will cause regression of Mullerian duct, but it leaves some remnants, that is prostatic utricle and appendix of testis. Now for female, there is no SRY gene, so that is why ovary is formed. So there is no AMH. So as there is no AMH, two Mullerian ducts. How many Mullerian ducts? Two Mullerian ducts will first form. Then these two Mullerian ducts will fuse with each other. And this fusion will be from down to up. That is from caudal to cranial. And after they fuse, then the septum inside will get resolved. And that's how we have the uterus, fallopian tube, cervix and upper 2/3 of vagina. Whereas lower 1/3 of vagina arises from the urogenital sinus. So right, so as there is no AMH, two Mullerian ducts will form, fuse and septal resolution, right? So there are remnants of the Wolffian duct. So what are the remnants of the Wolffian duct? The cranial remnant of the Wolffian duct is called apophoron. The caudal remnant of Wolffian duct is called paraphoron. And Wolffian duct remnant is called as Gartner's duct. And if this Gartner's duct gets blocked, it will form Gartner's cyst, which is a anterior vaginal wall cyst. So that's about the female genital tract. So we'll quickly repeat once again about the female genital tract. So there is no SRY gene, that's why ovary develops. No AMH, so two Mullerian duct form. They fuse caudal to cranial, and the septum inside will get resolved. And after the septum resolves, it results in uterus, cervix, upper two-thirds of vagina, and proximal fallopian tube. So as there is no testosterone, Wolffian duct will regress. Cranial remnant of the Wolffian tubule is epophoron. Caudal remnant of the Wolffian tubule is paraphoron. Wolffian duct remnant is Gartner's duct. Simple. Now coming to the external genitalia. External genitalia is also neutral. Now external genitalia, whether it will turn into male or female, depends on dihydrotestosterone. So what does it depend on? It depends on dihydrotestosterone, right? So if dihydrotestosterone is positive, it will result in male external genitalia. Yeah. So if dihydrotestosterone, is my volume fine now? Am I audible to everyone now? So if dihydrotestosterone is positive, it will be male external genitalia. Whereas if it is negative, it will be female external genitalia, right? So the upper part is the genital tubercle. This genital tubercle in males, this will become glans penis. Whereas this genital tubercle in females will become the clitoris. So genital tubercle in males will become the glans penis, whereas in females it will become the clitoris. Whereas genital fold will become in females labia minora, whereas in males it will become the ventral aspect of the penile urethra. Genital swelling in female it will become labia majora, and in males it will become the scrotum. So that's about the embryology. So I'll ask you 3 questions I want you to answer. So who is the deciding factor for the gonadal development? Who is the deciding factor for the gonadal development? Who is the deciding factor for the gonadal development? Excellent, Manan, Rahul, Shalini, very good. It is the SRY gene. So for the gonadal development, it is the SRY gene. Right. Now who will decide? Very good. SRY gene located on short arm of Y chromosome. Right? Right. Okay. And who is the deciding factor whether uterus will be present or absent? What about whether uterus will be present or absent? So whether uterus will be present or absent purely depends on the AMH. Very good. It depends on AMH. Whenever AMH is present, remember this guys, whenever AMH is present, uterus will be absent. And whenever AMH is absent, uterus will be present. And who is the deciding factor for the external genitalia? The deciding factor for the external genitalia is dihydrotestosterone. The deciding factor for the external genitalia is dihydrotestosterone, right? So most common cause of ambiguous genitalia means whether the genitalia is, don't know whether the genitalia is looking like a male or female, in between if it is looking, then we call it as ambiguous genitalia. In males, it is mainly due to congenital adrenal hyperplasia. The main enzyme deficiency for congenital adrenal hyperplasia is 21 alpha hydroxylase. 21 alpha hydroxylase. And this 21 alpha hydroxylase, you will always have 17 hydroxyprogesterone levels raised. Okay. And in males, it is the partial AIS. The most common cause of ambiguous genitalia in male fetus is partial AIS. Okay. So that's about the embryology. Now in anatomy, you got so many times. Okay. Right. So you want me to tell about the 21 alpha hydroxylase in little more in detail. Fine. So there is something called as congenital adrenal hyperplasia. Rahul, I think I'll take that in the last regarding the congenital adrenal hyperplasia in detail, as you want me to discuss little in detail. Yes, I'll discuss in the last. I'll open that PDF and I'll discuss for you in last. Okay. Right. Now, many times you got a question about Bartholin gland. So, Bartholin gland is something very simple, but yes, you got so many times question on that. So, you should be perfect with the Bartholin gland. So, Bartholin gland is also called as greater vestibular gland. So, Bartholin gland is also called as greater vestibular gland. This Bartholin gland lies in the superficial perineal pouch. Where does it lie? It lies in the superficial perineal pouch posterior to the vestibular bulb. These are homologous to bulbourethral gland in males. They are usually two in number and they lie at the junction of upper two-third and lower one-third. Upper two-third and lower one-third, right? They are two in number, compound racemose glands, right? This Bartholin duct opens into a groove between labia minora and hymen. Whenever this Bartholin duct gets blocked, it results in Bartholin cyst, and if it gets infected, it will result in Bartholin abscess. So this is the Bartholin cyst. So Bartholin cyst is fluctuant, non-tender and mobile. So you can do marsupialization if you have a recurrent Bartholin cyst. Recurrent Bartholin cyst treatment will be marsupialization. That is, you make an elliptical incision on this cyst, drain out the contents and keep it open instead of closing it so that there won't be any chance of recurrence. When this Bartholin cyst gets infected, it will result in Bartholin abscess. Most common organism causing Bartholin abscess is E. coli more than gonococci. So this is tender, fluctuant and mobile. Treatment for Bartholin abscess is incision and drainage, right? So this is marsupialization. Now, congenital Mullerian malformation is another one which we should be knowing. Many times they ask us as a question, especially the images of this. So yes. So what were the 3 steps in the formation of the Mullerian duct? The 3 steps in the formation of Mullerian duct were formation, fusion should be from below upwards, and the septal resolution. So you had formation, fusion and septal resolution. Whenever there is a problem in these 3 steps, it results in congenital Mullerian malformation, and I have a mnemonic for remembering the congenital Mullerian malformation. So my mnemonic for congenital Mullerian malformation is mud be sad. So what is this mud be sad? Bacha fell in the mud and he's sad. So how are we going to remember this? So first one is complete, no Mullerian ducts are formed. So that is called MRKH, Mayer-Rokitansky-Kushner-Hauser syndrome. Yeah, complete Mullerian agenesis. What is the chief complaint of MRKH? You people tell me. When there is absolutely no uterus, obviously what will happen? They will have no menstruation. So they will come to you with complaint of primary amenorrhea. Compartment 2. One duct is formed, one duct is not formed. So that will be unicornuate uterus. So this will have banana shaped uterus with single fallopian tube. So it will be banana shaped uterus with single fallopian tube. So 40% of them are associated with renal anomalies. 40% of them are associated with renal anomalies. The third one is didelphys. So didelphys, both Mullerian ducts are formed, but they didn't fuse. So didelphys will have 2 uterus, 2 cervix and 2 vaginas. Bicornuate is where the lower part is fused but upper part is not fused. Bicornuate is lower part is fused but upper part is not fused. So they will have 2 uterus, 1 cervix, 1 vagina. And the fifth one, see how beautiful is this classification. First 2 are formation defects. First one may entire ducts are absent. Second one duct is present, one duct is absent. Third and fourth, both ducts are present but they are not fused. Third one, completely not fused. Fourth one, lower part is fused and upper part is not fused. Fifth one, they both are fused, but the septum is not resolved. So fifth is septate. This is the most common uterine anomaly. This is the most common to have recurrent abortions. This is the most common to have infertility, right? Next, the sixth one is arcuate. Actually, this has been removed from the congenital Mullerian malformation as per European guidelines. So, this is no more considered as a abnormality in the European guidelines. Okay. So, the last one, seventh one, is in utero exposure to diethylstilbestrol. Very recently, there was a question for NEET students, but many times NEET questions repeat in FMG. So what does diethylstilbestrol cause? So this causes T-shaped uterus. T-shaped uterus. This causes vaginal clear cell adenocarcinoma. Vaginal clear cell adenocarcinoma. Thank you so much, Imran. And it also causes vaginal adenosis. So this is about the congenital Mullerian malformation. Now, what is the investigation of choice for identifying this Mullerian malformation? What is the investigation of choice for identifying this Mullerian malformation? So the investigation of choice for identifying this Mullerian malformation is MRI or 3D USG. MRI or 3D USG. Whereas gold standard is hysteroscopy, means you see from inside, or laparoscopy, that is you see from outside. But most of the uterine malformations are picked up by HSG, that is hysterosalpingography. But major books tell HSG has no role. Especially HSG has no role to differentiate between bicornuate and septate. So for bicornuate and septate, I would prefer MRI, या hysteroscopy, या laparoscopy, then HSG. Okay, but you got an MCQ on this. You got this picture once in your exam for your as an image base. So can you see this? How are you going to identify in the exam if you get this in the question? So you have to identify this with it is a conical shaped with spiral. Conical shaped with spiral. So what is this called as? This is called Leach-Wilkinson's cannula, and this is used mainly in hysterosalpingography. This is the Leach-Wilkinson's cannula and is mainly used in hysterosalpingography, right? So as I told you, HSG is ideally not useful for distinguishing between bicornuate and septate, but old ways are like when you see the intercornual distance is more than 4 centimeters, the intercornual angle is more than 60 degrees, we call it as bicornuate. But nowadays this is not very classical and this is not ideal. So nowadays mainly we use 3D USG. If you see, the angle between them is more than 75 degrees. Now this is the hysterosalpingography. This is the hysteroscopy and laparoscopy. So this is the hysteroscopy where you are seeing two cavities. This is a laparoscopy where you are seeing the two uterine cavities from outside. Now this is the septate. So if you are seeing here, it is single from outside, but it is having two cavities from inside. So this is a septate. So septate on HSG, the intercornual angle will be less than 60 degrees and the intercornual distance will be less than 4 centimeters. Yes, but the ideal way to differentiate them, I told you, is MRI. How are we going to differentiate on MRI? So MRI may you draw one line joining both the cornu. Okay? You draw one line joining both the cornu. And then you see the fundal contour. If the fundal contour is above the line joining both the cornu, then it is septate. Draw a line joining both the cornu, and if the fundal contour is below the line joining both the cornu, then it is bicornuate. Okay? So for example, please see here. This is the MRI picture. Cornu means where the fallopian tube attached to the uterus. So now let me draw a line joining both the cornu. Now let me draw a line joining both the cornu. So let us draw a line joining both the cornu. So the fundal contour is now below. The fundal contour is now below. So what is this? Is this bicornuate? Yeah, is this septate? So when the fundal contour is dipping the line joining both the cornu, this is bicornuate. This is bicornuate. Now please see this one. So we draw a line joining both the cornu and this is the fundal contour. So fundal contour is above the line joining both the cornu. So this will be the septate. So this will be the septate, right? Very good. Excellent. So on HSG, if you see 2 cervix, 2 uterus, 2 vaginas, this is nothing but didelphys, right? Now this one, banana shaped uterus with single fallopian tube, this is unicornuate. All these images are important. Now treatment. So the most common indication for treating is recurrent abortions, when they have recurrent abortions. So for bicornuate or didelphys, you have to remove the medial half of the uterus and you have to stick it like a single uterus. Stitch it like a single uterus. So that is called as metroplasty. And the most commonly done metroplasty is Strassman's metroplasty. Whereas, what is the management for septate uterus? Septate uterus, we do transcervical hysteroscopic resection. So that is from down you try to remove the septum. So that's called transcervical hysteroscopic septal resection. That's all. This is about the congenital Mullerian malformation. So what did we discuss in congenital Mullerian malformation? So we have mud, B, SAD, MRKH, unicornuate uterus, didelphys, bicornuate, septate, arcuate, and in utero exposure to diethylstilbestrol. The investigation of choice is 3D USG or MRI, whereas gold standard is hysteroscopy and laparoscopy. Most common indication for treatment is recurrent abortion. For didelphys and for bicornuate, it is mainly the Strassman's metroplasty, whereas for septate uterus, we do go for transcervical hysteroscopic septal resection, right? So can you answer this? Bicornuate uterus is due to. Come on guys, now let us see how much you are going to answer. It's due to incomplete fusion of uterine cavity, incomplete fusion of paramesonephric duct, incomplete fusion of mesonephric duct, incomplete formation of vagina. So first and foremost, you should not answer as incomplete fusion of uterine cavity because it's not just incomplete, it is incomplete fusion of Mullerian ducts. The other name for Mullerian duct is paramesonephric duct. So it is mainly due to incomplete fusion of paramesonephric duct. Okay. The most important indication of surgical repair of a bicornuate uterus is recurrent abortion. So recurrent abortion is also called as habitual abortion. Next, coming to the reproductive physiology. You know, why do we menstruate? Our menstruation is mainly because of the certain changes occurring at the brain, certain changes occurring at the ovary, and certain changes occurring at the uterine cavity. So first, seeing the changes at the brain, so we have something called as HPO uterine axis. From our hypothalamus, there is pulsatile GnRH secretion. That is, GnRH will come, go. GnRH will come, go. So it is pulsatile GnRH secretion. This pulsatile GnRH secretion will go act on the pituitary gland. That will release the FSH and LH. That will go act on the ovary to release estrogen and progesterone. That will go act on the uterus, right? So this pulsatile GnRH secretion, we have leptin and kisspeptin. So leptin is mainly released from the adipose tissue. So leptin helps in the pulsatile secretion of GnRH, whereas GABA and neuropeptide Y will decrease the pulsatility of GnRH secretion. Now, you know, this is a very simple but very strong statement. So have you ever observed just before our exams, our periods become completely irregular? Means whenever we are stressed out, GABA increases, and that decreases the pulsatility of GnRH, and that's why our cycles will become irregular. Have you also observed thin girls attain menarche early, whereas those girls who are little on obese side attain menarche, thin girls attain menarche late, whereas the obese girls attain menarche early? That is because of the leptin. That is because of the leptin, right? So next, coming to the ovarian cycle. So first and foremost, we have the development of follicle. So always remember there is something called as follicle, something called as oocyte, something called as ovarian cycle, which are all of three terminologies are different. The development of follicle is called folliculogenesis. So follicle is like a balloon, oocyte is like a marble inside it. The development of that balloon is called folliculogenesis. It takes 84 days. Whereas the marble inside is stuck at the prophase of meiosis 1, and it gets completed only at the time of ovulation. So in the folliculogenesis, the oogonium develop into primordial follicle, which will develop into primary follicle, and that will develop into secondary follicle, and that further will become the tertiary follicle and Graafian follicle. Now most students will always assume, this is something basic, but most of them will always think it is from the primordial follicle to Graafian follicle which is taking place in our ovarian cycle, which is a wrong, guys. I told you folliculogenesis is 84 days and our ovarian cycle is just 28 days. So from the primordial to the antral follicle is FSH independent. It can happen by itself. But from antral follicle to dominant follicle, it is FSH dependent, and this takes place in the ovarian cycle. So in the ovarian cycle, we have something called as follicular phase. Day 2 to day 3, FSH recruits the antral follicles. Day 5 to day 8, there will be selection of dominant follicle. How do you select the dominant follicle or the Graafian follicle? The follicle with maximum FSH receptors is the one which is going to become dominant follicle. This FSH is in too much love with estrogen. This stimulates the granulosa cells to produce estrogen and inhibin B. But estrogen is esan faramosh. It does not like FSH. So this causes negative feedback on FSH. But when estrogen is around 200 picogram per ml, lasting for 48 to 50 hours, this loves somebody else. So what does FSH estrogen loves? Estrogen loves LH. So that causes LH surge onset. And next we have the ovulation. So from LH surge onset to ovulation, it takes 36 hours. From LH surge peak to ovulation, it takes 10 to 12 hours. Now, LH is the one which helps in the resumption of meiosis 1. And at the time of LH surge peak, we have first polar body released. And at the time of ovulation, we have the secondary oocyte released. So this is some important points, like you should be knowing. Okay. Now, once after ovulation takes place, we have the corpus luteum. Now, one very important point. Most of you think again that ovulation is just because of the LH surge. But ovulation is due to both LH surge, FSH surge, LH and FSH surge. Ovulation is due to both LH and FSH surge. So once the ovulation takes place, the dominant follicle is now called as corpus luteum. It is now called as corpus luteum, and that is called as luteal phase. Now corpus luteum secretes both hormones, guys. It secretes progesterone, but it also secretes estrogen. It secretes inhibin A and relaxin. Corpus luteum, if not fertilized, then the lifespan is only 14 days. So that is why our second half of the menstrual cycle is always constant. Corpus luteum is fertilized, then it will be 10 to 12 weeks. Lifespan will be 10 to 12 weeks. Maximum activity of the corpus luteum is on day 8 post ovulation. That is why if you want to know whether somebody is ovulating or not ovulating, you have to measure the serum progesterone on day 22. And if it is more than 5 nanogram per ml, it is ovulation happening. So day 22, when you measure the serum progesterone, if it is more than 5 nanogram per ml, it means ovulation is taking place. Okay? Yes, Roy, you're correct. Now, why did I go on telling so much is mainly for this picture, guys. So sometimes you can get this picture in the exam and they can ask you, to label it. So I will just erase the names of the different hormones. I want you people to tell me the different. So now tell me, what is this red color one which is increased only on day 22? What is this red color which is increased only on day 22? Yes, very good, Shalini. This is the progesterone. Progesterone. What is this blue color one which is increased only on day 14? So that is the LH surge. I told you along with LH surge you have FSH surge. Can you see here? This pink one which is increasing along with LH surge. This is the FSH. Now, estrogen has how many peaks? Estrogen has how many peaks? Estrogen has two peaks, guys. Estrogen has two peaks. Can you see? Estrogen has two peaks. First peak and second peak. First peak and second peak. Correct. Estrogen has two peaks. This is most important, which you have to remember. Now, second, that's about the ovarian cycle and the hormonal, what hormones you have to remember. Now, uterine cycle, I want you to keep it very simple. So, we have the proliferative phase, we have the secretory phase, we have the menstruation. So, withdrawal of estrogen and progesterone will lead to menstruation. So, estrogen helps in the proliferation of endometrium. Estrogen leads to proliferation of the endometrium. So, estrogen causes proliferation of endometrium. Whereas in the second half, that is the secretory phase, you have estrogen and progesterone together. But remember this very important point. Remember this very important point. అక్కడ కూర్చో కూర్చో అక్కడ కూర్చోండి అల్లరి చేయకండి. So proliferative, I'm very sorry. So estrogen causes proliferation of the endometrium, whereas in the secretory phase you have estrogen and progesterone together, and when you have estrogen and progesterone together, progesterone acts like a dominant pati, very dominant pati. So what does this progesterone do is it is anti-mitotic, and this inhibits the estrogen receptors on the endometrium. So progesterone is anti-mitotic and it inhibits the estrogen receptors on the endometrium. So estrogen helps only proliferation of the endometrium, whereas progesterone is anti-mitotic and this inhibits the estrogen receptors on the endometrium, right? So there's a very important point which I want to actually convey from this picture. I told that estrogen causes proliferation of endometrium. है ना? So whenever estrogen levels are high, our endometrium will be thick. So for example, who is the villain in endometrial hyperplasias and endometrial cancers? Who is the villain in the endometrial hyperplasias and endometrial cancers? Estrogen. And if somebody is having heavy menstrual bleeding, what can be given as a treatment? Progesterone can be given as a treatment. I told you that progesterone is a dominant pati. So it will slap estrogen and tell, chup, no more growth. So whenever estrogen is a villain, who comes as a hero? Progesterone comes as a hero. Right? So whenever you are giving estrogen and progesterone together, it is mainly the progesterone which is going to take over and act like a savior. So on the whole, from whatever I told till now, can you tell me one point, guys? Are OCPs protective to endometrial cancer? or does it cause endometrial cancer? Are OCPs protective to endometrial cancer or does it cause endometrial cancer? Excellent. Very, very, very good. So as oral contraceptive pills contains estrogen and progesterone acts like a dominant pati, it inhibits the growth of the endometrium. So OCPs are protective to endometrial cancer. So I hope this point is very clear to all of you. I'm somehow feeling it might come in your exam, so you all should be in a position to answer this. So these are some important points which you should know in the reproductive physiology. So normally whenever there is ovulation, when you take a scan, this is how the endometrium will look like, and this is called as trilaminar endometrium. Trilaminar endometrium. And the first sign on endometrial biopsy post ovulation is subnuclear basal vacuolation. Subnuclear basal vacuolation, right? So in a 42 days of menstrual cycle, ovulation occurs at, so I told you always that the last 14 days are constant. So you should do 42 minus 14. So that is 28th day. That is 28th day, right? Next, a very, very, very important, very important topic we are going to discuss, that is amenorrhea. So amenorrhea means complete absence of menstruation. You have two types of amenorrhea, primary amenorrhea and secondary amenorrhea. Primary amenorrhea and secondary amenorrhea, right? So primary amenorrhea can be true primary amenorrhea, or it can also be crypto or false primary amenorrhea. So crypto or false primary amenorrhea, there is no problem in the hypothalamo-pituitary ovarian axis, but the menstrual blood flow is not able to come out. There is the outflow tract obstruction, and because of that outflow tract obstruction, the menstrual blood is not able to come out, right? So imperforate hymen patient will mainly present to you with primary amenorrhea with cyclical pain abdomen, and they can also have acute retention of urine. And when you do local examination, you will see a tense bluish bulging hymen. Apart from imperforate hymen, the other thing what we have is transverse vaginal septum and cervical stenosis, right? So what is the treatment for imperforate hymen? So the treatment for imperforate hymen is you put a X-shaped incision or cruciate incision. And whenever you're suspecting imperforate hymen, you should do a per-rectal examination where uterus will be felt. And on USG, you will see the uterus is present. On USG, uterus is present, right? Correct. So that's about the imperforate hymen. Now, first and foremost, I think I didn't tell you the definition. So what is the definition of primary amenorrhea? So it is the absence of menstruation by age 13 years without secondary sexual characteristics, or it is absence of menstruation by age 15 years with secondary sexual characteristics. So it is absence of menstruation by age 13 years without secondary sexual characteristics, and it is absence of menstruation by age 15 years with secondary sexual characteristics. So in the presence of secondary sexual characteristics, you can wait up to 15 years. In the absence of secondary sexual characteristics, you wait only up to 13 years. And one more definition we have, after secondary sexual characteristics developed, if no menstruation by 5 years, then also you can call it as primary amenorrhea. So after secondary sexual characteristics, if there is no menstruation by 5 years, then also you can call it as primary amenorrhea. So what is the most common cause of primary amenorrhea? Turner syndrome. Second most common cause is MRKH, that is, and third most common cause is AIS. Third most common cause is AIS, that is androgen insensitivity syndrome. Now, I'm going to simplify the amenorrhea topic as much as possible to you all. So what am I going to do is, everywhere, whenever you get a question on amenorrhea, you will get a clinical scenario. And in that clinical scenario, you have to observe few points. That is, whether secondary sexual characteristics are present or absent, whether uterus is present or absent, what is a karyotype. And when you observe these three things, you will be able to answer what type of amenorrhea we are dealing with. Okay? So basic idea of this is like, when you go back to the exam, it should be a cakewalk while you're answering. Everything should strike your brain while you're answering your MCQs. That is the main purpose of this session, right? So whenever I tell secondary sexual characteristics are present, so secondary sexual characteristics are present means estrogen is present or absent. So secondary sexual characteristics are present means estrogen is present. Estrogen is present. Okay, keep that in your mind. So first abnormality. So I made a beautiful tables here. The first abnormality what we are going to see is MRKH. So MRKH is, there is nothing problem, but they don't have the uterus because Mullerian duct didn't form. So karyotype is 46XX. Gonad is ovary, and as ovary is present, there will be production of estrogen. So secondary sexual characteristics are positive, but uterus is absent. Even lower one third of even vagina also, lower one, upper one third of vagina is absent, upper two third of vagina is absent, right? MRKH stands for complete Mullerian agenesis. Yeah, Mayer-Rokitansky-Kushner-Hauser syndrome. In the mud-B sad, M is MRKH. That is, both Mullerian ducts are absent. Both Mullerian ducts are absent. So what will be the management for this patient? You do vaginoplasty so that she'll have a good married life. And this vaginoplasty should be done just before marriage. And you people tell me, don't see here, can she have her own genetic child or she'll not have her own genetic child? So whether we have our own genetic child or not depends mainly on whether we have ovary or not. And as the ovary is present here, we can have our own genetic child because this ovary can produce oocytes. So can have own genetic child. Right. The second abnormality I'm going to discuss is AIS. Now AIS is like beautiful model, like the model type, full, tall, slim, very beautiful. It is, but to break your heart, it is not a female, they are actually males. So the karyotype here is 46XY. And whenever SRY gene is present, obviously the gonad will be testis. And secondary sexual characteristics are this. But the problem, what is the problem here? So this is a testosterone receptor defect. All the testosterone here is getting converted into, as it is not able to act on its receptor, it's getting converted into estrogen. And because estrogen is present, secondary sexual characteristics will be positive. So breast development will be there, but axillary and pubic hair will be absent. Okay. So uterus is also absent because they are males. So, but we are going to continue to rear them as a female. So that is why we have to do vaginoplasty. These gonads have the risk of malignancy. So you do gonadectomy after puberty. Why after puberty? Because we are waiting for the secondary sexual characteristics to develop. After you have done the gonadectomy, you have to give her hormone replacement therapy with estrogen. Can she have her own genetic child? No. She has to go for adoption. She has to go for adoption. Next one is Turner syndrome. So Turner syndrome is 45XO. Now guys, please remember, you have pure Turners. You also have Turner mosaic. Turner mosaic means some chromosomes. See, we have 46 set of chromosomes, right? So yeah, these people have some chromosomes of them are 45XO. Some cells in them are 45XO. Some cells in them are 46XX. Absolutely normal. So Turner syndrome, Turner mosaic can have some normal karyotype cells, some abnormal karyotype cells. Turner mosaic will present you with secondary amenorrhea, premature ovarian failure. Pure Turners will present you with primary amenorrhea, right? So they will have streak ovaries. Streak ovaries. When ovaries is not there, obviously secondary sexual characteristics are not developed. They'll have chote uterus, infantile uterus. So for them, you have to go for hormone replacement therapy with estrogen and progesterone and adoption. Next, we have a Swayer's syndrome. Swayer's syndrome, 90% it is idiopathic, but 10% it is because of the SRY gene mutation. 10% it is due to SRY gene mutation. So again, this is 46XY, but as there is no SRY gene, they're going to have streak gonads. No estrogen, so secondary sexual characteristics are not developed. They will also have infantile uterus. So you have to go for gonadectomy as well as hormone replacement therapy with estrogen and progesterone, and you have to go for adoption. Next, if in your exam they give you something like, primary amenorrhea with anosmia, then you're discussing something called as Kalaman syndrome. Kalaman syndrome. So Kalaman syndrome is anosmia plus absence of GnRH production. So they are 46XX. Gonad is ovary, but GnRH is not there, so ovary is not getting stimulated. So estrogen is not there, so secondary sexual characteristics are not developed. Uterus is present. You have to give either pulsatile GnRH or HCG. This is all 5 important which you should know with respect to the primary amenorrhea. So I hope you all understood the primary amenorrhea syndromes, right? So to simplify and to summarize again, so if you have, yes, very good Chandar, sometimes Kalaman syndrome patients can also have color blindness and ataxia. Yes, sometimes they can have. Turners, you should know head to toe all the findings. Their short stature, webbed neck, low hairline, short fourth metacarpal, cubitus valgus, streak gonads, lymphedema, coarctation of aorta with bicuspid valve. They are prone for getting autoimmune diabetes, thyroid disorders, hearing problems, horseshoe kidney. Okay. Right. So if you have 46XY with uterus absent, secondary sexual characteristics present, it is AIS. 46XY with uterus present, but secondary sexual characteristics absent, then it is Swayer's. See the combination. This combination you have to remember in exam. 46XX. Uterus absent, secondary sexual characteristics positive. MRKH. 46XX, uterus present, secondary sexual characteristics absent, Calamans. 46XX, uterus present, secondary sexual characteristics present, then it is imperforate hymen. 45XO, uterus present, secondary sexual characteristics absent, then it is your Turner syndrome. Right? Clear, guys? So whenever you are having primary amenorrhea, first you have to always do karyotyping. So coming to next one, that is secondary amenorrhea, that is absence of menstruation for 6 months or 3 less than 4 cycles, coarctation of aorta with bicuspid valve. Okay, can you answer me this question? Ki why stress, eating disorder, excessive exercise, athletes, this leads to secondary amenorrhea. Can anybody? Because stress increases the GABA. Eating disorder, excessive exercise, athletes, all this decreases the leptin and they increase the endorphins. These all in turn decreases the pulsatility of GnRH. That is why they are included in the amenorrhea causes. Okay, guys? So ovarian causes may we have premature ovarian failure. That is all the oocytes are depleted before the age of 40 years. So it can be due to Turner's. We have Fragile X syndrome. Very good, Roy. Excellent. Absolutely correct. So PCOS, Savage syndrome. Savage syndrome is resistant ovary syndrome. Estrogen producing ovarian tumor, oophorectomy, radiotherapy and chemotherapy. So premature ovarian failure is where you have all the oocytes getting depleted before 40 years. So this can be idiopathic or this can be autoimmune, oophorytis, Turner mosaic and Fragile X syndrome. So here usually FSH is more than 40, and on transvaginal sonography, antral follicle count is decreased. So what is the treatment? Treatment is IVF with donor oocytes. Treatment is IVF with donor oocytes. Savage syndrome or FSH receptor mutation, FSH is not able to act on its receptors. So because of that, what will happen? No follicle will develop. As the FSH is not able to act on its receptors, so FSH levels will be more than 40. Up to antral follicle count, it is FSH independent. So on transvaginal sonography, antral follicle count is more. Again, they have to go for IVF with donor oocytes. PCOS is the most common cause for infertility. Treatable infertility, as well as it is the most common cause of secondary amenorrhea. Why do we have PCOS? Most of the patients with PCOS have insulin resistance. So most of the patients with PCOS have insulin resistance. And because of that insulin resistance, there is increased insulin and increased IGF-1. And this increased insulin and IGF-1 cause theca cell hypertrophy. That releases a lot of testosterone. This gets converted into estrogen in the ovary. But there's so much testosterone that some of the testosterone will now go into fat cells and gets converted into estrone. Now whether it is estradiol or estrone, both are estrogen. What does estrogen do to LH and what does estrogen do to FSH? What does estrogen do to LH and what does estrogen do to FSH? Excellent. It inhibits the FSH. So you see, it is inhibiting the FSH. As it is inhibiting the FSH, so what does it lead to? It leads to anovulatory cycles, because FSH is required for the development from antral follicle to dominant follicle. So as it is inhibiting the FSH, we'll have anovulatory cycles. And this in turn will cause positive feedback on LH. And one more reason for anovulatory cycles is LH should not be persistently raised. It should be suddenly raised. So as LH is increased, this increased LH can lead to theca cell hypertrophy. And this vicious circle goes on and on and on. So I hope you all understood the pathophysiology of PCOS, right? Okay, right. So to deal with this, the principal treatment in PCOS, for insulin resistance we give metformin, and for the fat cells we ask them for weight loss. So these are the two principal management what we have for the PCOS. One is metformin and the other one is weight loss. Right? Did you understand now why the treatment is metformin and weight loss? A very important idea for diagnosing PCOS. Old criteria is Rotterdam's criteria, where you should have 2 out of 3 positive. So what is the 2 out of 3 positive? They should have oligo or anovulation, hyperandrogenism, which is clinical or biochemical, and they should have peripherally arranged follicles of 2 to 9 mm size, and there should be more than 12 follicles. I repeat, what is the Rotterdam's criteria? 2 or oligo or anovulation, hyperandrogenism, which can be clinical or biochemical. You should have peripherally arranged follicles of 2 to 9 mm size, more than 12 follicles. How much, guys? More than 12 follicles, right? What is the Eschrey criteria? So Eschrey criteria has come very recently. And in Eschrey, which are more in PCOS, and what all hormones which are less in PCOS. So this picture can come in the exam. So what is this picture? So this picture, how are you going to identify? You're going to see that all the follicles are peripherally arranged. What do you call this as? What this arrangement is called as, guys? This is called chain of pearl. Chain of pearl appearance. Right? Yeah, and when you are examining the ovaries will be bulky and white color. And this is called as oyster shell ovaries. This is called as oyster shell ovaries. Okay? Right. What are the hormones which are more in PCOS? What are the hormones which are less in PCOS? So estrogen is more, LH is more, insulin and insulin growth factor is more, testosterone is more, both total and free, LDL and triglycerides are more, and AMH levels are also more. AMH levels are also more. What are the hormones which are low? Progesterone, because it is anovulatory cycles. FSH is low. Sex hormone binding globulin is low. HDL is low because of the increased estrogen. First of all, anovulation, so complication is infertility. Increased estrogen can lead to endometrial hyperplasia, endometrial cancer, breast cancer. They can have metabolic syndrome and diabetes, depression and fatty liver. Treatment, I have simplified and made it in this beautiful table, guys. Very beautiful table. So principal management is weight loss. Even if they lose 10% of their body weight, everything will become perfect. So weight loss and insulin sensitizer, that is metformin, and another newer insulin sensitizer what we have is myo-inositol. Now for young girls who want to regularize cycles, you can give OCPs every 21 days or you can give withdrawal bleeding with progesterone. For hirsutism, the drug of choice will be OCPs containing cyproterone acetate. And those patients who come to us with infertility, for them you can do ovulation induction with letrozole. Ovulation induction with letrozole. Other drugs what we can give are clomiphene citrate and gonadotrophins. Last resort is laparoscopic ovarian drilling. That is, you drill the ovary, but that will be the last, so that theca cells get burned. So that once theca cells get burned, testosterone levels will drop down, but it's temporary. So that's about the PCOS. So now coming to the uterus. So in uterus, we mainly have Asherman syndrome. So what is Asherman syndrome? Asherman syndrome is the damage to Decidia basalis. And due to the damage to Decidia basalis, there will be adhesion of the anterior and posterior wall of the uterus. It can be due to repeated DNC, overzealous DNC, previous cesarean section and tuberculosis. But highest risk is when they have overzealous curettage postpartum DNC. So investigation of choice and gold standard is hysteroscopy, where you will on, and you can also do HSG, honeycomb appearance. Treatment is hysteroscopic adhesiolysis. Through hysteroscopy, you break all the adhesions. After you break all the adhesion, you have to insert a copper T so that it won't readhere, and you can give estrogen and progesterone supplementation. We left with compartment 3, that is pituitary gland. So we have something called as Sheehan syndrome. What is Sheehan syndrome, guys? Very favorite of student and usually many times comes in the exam. So postpartum pituitary necrosis. The blood supply to the pituitary gland is very much increased in pregnancy. So post-delivery, when there is a PPH, the pituitary gland is the first to undergo necrosis. So it is postpartum pituitary necrosis due to PPH. First hormone which is lost is growth hormone. Followed by the clinical picture, we mainly have the lactational failure, amenorrhea, hypothyroidism and hypocortisolism. So all the anti-pituitary hormones are lost. Prolactin, FSH, LH, TSH, ACTH. So treatment will be hormone replacement therapy with estrogen and progesterone. You give thyroxine and you supplement them with cortisol. Okay. Next, coming to the prolactinoma. You got a lot of questions on prolactinoma, guys. So prolactinoma is a tumor in the pituitary gland. A tumor in the pituitary gland. You might have microadenoma and macroadenoma. Microadenoma is less than 1 centimeter. Macroadenoma is more than 1 centimeter. The classical triad of prolactinoma is amenorrhea, decreased libido and infertility, and galactorrhea. So amenorrhea, galactorrhea, decreased libido and infertility. So this is a class, right? So that's about the all the causes of secondary amenorrhea. How do we work up for a case of secondary amenorrhea? First you have to do UPT. If UPT is negative, you can prolactin. Then we have something called as progesterone challenge test. So you give her 5 days of medroxyprogesterone acetate and then you withdraw. Why am I doing progesterone challenge test is because I know that most common anovulatory cycle is PCOS. So what I'll do, I'll give her 5 days of progesterone and then I'll withdraw. If bleeding is present, means it is not the problem of estrogen and progesterone, it is a problem of uterus. So on estrogen and progesterone challenge test, when you withdraw, if there is no bleeding, then it is Asherman syndrome. If bleeding is present, then you have to measure the serum FSH. If serum FSH is less than 5, it is hypothalamo-pituitary failure. If serum FSH is more than 20, it is ovarian failure. Right? So that is regarding the, so always remember, in ovarian failures, serum FSH will be high, actually more than 40. And hypothalamo-pituitary FSH levels will be less than 5. Remember this point. And when FSH is between 5 to 8, it is considered to be normal. Clear, guys? So that's about the secondary amenorrhea. So that finishes the amenorrhea, very important topic. I hope you all understood the amenorrhea and you're trying to remember the amenorrhea. Now we'll go to the infertility, guys. Now we are going to discuss about the infertility. So what does infertility means? Husband in Dubai, wife in India, married for 2 years. Do you call it as infertility? No, right? So that is not called as infertility. So when do you call infertility? So infertility is when husband and wife are married for more than 1 year, but in spite of regular unprotected intercourse, if they're not able to have baby, then we call it as infertility. So if age of the woman is more than 35 years, you're not going to wait for 1 year, you're going to wait only for 6 months. Now, infertility can be due to both male and female. Male accounts for 40 to 30%, whereas female accounts for 40 to 50%. So, the female causes can be divided into ovarian, tubal, combined, and unexplained. So, first, the ovarian factors for female infertility: PCOS, ovarian dysgenesis like Turner's, premature ovarian failure या Savage syndrome, luteal phase defect, tumors, chemotherapy, radiotherapy, oophorytis. Whereas the tubal factors also account for 30 to 40%. So can you name some tubal factors? Don't see here, you people tell me some tubal factors which can lead to infertility. Okay, tubal is senior, uterine you name. Till then I'll discuss the tubal factors. So peritubal adhesions, wherever cilia are damaged, like salpingitis, Carter-Jenner syndrome, all these can be tubal factors for female infertility. है ना? I want you people to tell me some uterine factors which can lead to infertility. Yes, some uterine factors which can lead to infertility. Yes, fibroid. Septate uterus, right? Very good. Tuberculosis, Asherman, correct. Endometriosis, very good. Tuberculosis, Correct. Tuberculosis also. Right. Cervical may anti-sperm antibody on the cervix. Unexplained. Accounts for 10 to 15%. So, anovulation, you also have hypothyroidism and hyperprolactinemia. How do you know? So, whenever a patient comes to you with infertility, for women, you are going to do ultrasound, indicators of ovulation, HSG, and for men, you have to do the semen analysis. So, how do you know somebody is ovulating or not ovulating? You can know whether somebody is ovulating or not ovulating by the indirect, direct, and conclusive factors. Conclusive is she's pregnant. Direct is when laparoscopy you visualize the corpus luteum. Indirect may if she has regular cycles. What is Mittelsmarch? Whenever you have painful cycles and the pain persisting only on the first day of menstrual cycle, that's called primary spasmodic dysmenorrhea. And if pain is present throughout the entire periods, pain appears before, then it is secondary congestive dysmenorrhea due to some disorders. Primary dysmenorrhea is usually on the first day of menstrual cycle. And it's good because it indicates we are dealing with ovulatory cycles. So Mittelsmarch is mid-cycle ovulation. So because of the in middle of the cycle you'll have ovulation, and because of that ovulation you're going to have pain in the iliac fossa. So mid-cycle pain in the iliac fossa due to ovulation, right? So PMS is also an indication that she's having the ovulatory cycle. So PMS women go crazy just before periods because of the query progesterones. It can be due to serotonin elevated and many other hormones, right? Post ovulation, because of the progesterone, there will be rise in the basal body temperature, right? And cervical mucus changes. That is, before ovulation, our cervical mucus will be thin, copious, can be stretched between two fingers. That's called spin barket. Furning will be positive. After ovulation, under the influence of progesterone, it becomes thick, scanty, breaks on stretching, furning is absent, right? Next, you can also measure. So you can measure the serum progesterone day 22. Day 22 endometrial biopsy. USG may you will see rupture of follicles and fluid in the pouch of Douglas and triple line endometrium. You can do the maturation index. You will see increased intermediate cells. There are three cells in the vagina, parabasal and basal, which are under no hormonal influence. Intermediate are blue polygonal under the influence of progesterone. Superficial are pink polygonal under the influence of estrogen. And you can also do the urinary alert search. So these are certain indicators which tell us that whether we are dealing with ovulatory cycles or anovulatory cycles. Okay. So these are the cells which I told you just now. So pink polygonal cells are superficial cells which are under the influence of estrogen. Blue polygonal cells are intermediate cells which are under the influence of progesterone. Parabasal and basal cells are under no hormonal predominance and they are mainly seen in menopause. Best marker to find out whether somebody is having ovulatory cycles or not, ovarian reserve, is AMH. If AMH is less than 1, it is a poor ovarian reserve. If AMH is between 2 to 4, it is normal. Second best is you have to measure the antral follicle count on TVS. So normally the antral follicle count is between 5 to 8. If antral follicle count is less than 5, it is considered to be abnormal. Less reserve. So what are the different drugs we have for ovulation induction? You have tamoxifen, dexamethasone, but better drugs than that is clomiphene citrate, letrozole, gonadotrophins. So clomiphene citrate is a SERM, selective estrogen receptor modulator. Dose, you can start from 50 milligrams, you can go up to 150 milligrams per day. Start on day 1 to day 2 cycle and give her for 5 days. Very dangerous side effect by this is visual disturbance. Okay. Letrozole is an aromatase inhibitor. So it inhibits the conversion of testosterone to estrogen. That's how it prevents the negative feedback. So dose is 2.5 milligram per day. To maximum you can give 5 milligrams per day for 5 days. So this is associated with congenital malformation. Gonadotrophins, you can give human menopausal gonadotrophin. It is made from the urinary extract of menopausal women, which contains 75 international units of FSH and 75 international units of LH. Okay, this question has come to you in the exam. So this is a very important question. A patient treated for infertility with clomiphene citrate presents with sudden onset of abdominal pain and distension with ascites. And this is the USG. What is the most probable cause? Uterine rupture, ectopic pregnancy, multifetal pregnancy, hyperstimulation syndrome. So this is called as, very good Stuti. So this is called as hyperstimulation syndrome. The only dangerous side effect with ovulation induction drugs is there can be multiple cysts being developed in the ovary, and that is called as hyperstimulation syndrome, ovarian hyperstimulation syndrome, right? So for tubal factors, the first line investigation is HSG, hysterosalpingography, because it is non-invasive. But the only disadvantage of HSG is sometimes when dye comes, no, suddenly the tubes undergo spasm. Next step or the gold standard is laparoscopic chromoperturbation. There was one question to you all in this exam. What is a dye which you use in laparoscopic chromoperturbation? Methylene blue dye. Methylene blue dye. What is the advantage of this? You are not going to see only the tube, you are going to see adjacent structures. It's both therapeutic and diagnostic. You have direct visualization. But the disadvantage is it's invasive, expensive, uterine cavity is also not seen. How do you treat the tubal factors? When you have proximal tubal blocks, so this is a HSG picture. This is a HSG picture. This is laparoscopic chromoperturbation. So when you have proximal cornual blocks, you will do bilateral catheterization or cannulation. When you have mid-segmental block, you will go into do tubal recanalization. And when you have distal block, you are going to do, if it is mild, fimbrioplasty. Any severe tubal blocks, IVF is the best, so that there is no chance of ectopic pregnancy. Okay. So lady with infertility with bilateral tubal block at cornu, best method of management is, so they are asking you best method. So what should be the answer guys? So as they are asking best method, what should be the answer? IVF. So best method will be IVF. No, the best method will be IVF. So any severe tubal blocks, the best method will be IVF. Now please see the difference between the previous question and this question. An infertile woman has bilateral tubal block at cornu on HSG. Next step in the treatment is, so if somebody asking you what is the next step in the treatment, then you have to go for, see, with when you push the dye, tubes can undergo sudden spasm, है ना? So what you can do, you have to go for the next step, that is laparoscopy and hysteroscopy. Okay. So in the male may most important is semen analysis. So semen analysis, there is a recent change in 2021. So semen volume now has been changed to 1.4 ml or more, guys. pH 7.2 or more, count 15 million, per ejaculate more than 30 million. Motility, this is one important which you all should learn. Total motility should be more than 42%. Progressive motility 30%. Vitality 54%. Morphology should be 4%. This is the new one. So can I repeat the new one once again? Volume should be 1.4 ml or more. Per ejaculate, it should be more than 39 million. pH should be 7.2 or more. Count should be 15 million or more. Motility, total motility should be 42%. Progressive motility should be 30%. Vitality is 54%. Morphology is 4% or more. Morphology is 4% or more. ठीक है? Leukocytes should be less than 1 million. Round cells less than 5 million. Agglutination less than 10%. If there is complete absence of semen, that's called aspermia. If there is zero sperm counts, semen is there, but sperm count is zero, then we call it as azoospermia. Sperm count is less than 15 million, we call it as oligospermia. If morphology is abnormal and it is less than 4% normal, teratozoospermia. Motility is less than 42%, asthenospermia. So whenever you have oligospermia, you have to just give her some multivitamins and antioxidant for 3 months and everything becomes normal. But how do you work up for azoospermia is a question. So what do we do for azoospermia? So whenever we have azoospermia, first take a peripheral smear. If you have leukocytes, give antibiotic. Do a serum FSH and TSH and prolactin. Next, you check the FSH, LH, testosterone. Now this is important, guys. Agar FSH and LH and testosterone all are low, then the problem is hypothalamo-pituitary, Kalaman syndrome. Give pulsatile GnRH, yeah, HCG. If FSH and LH are high, but testosterone levels are low, then it's a testicular defect. Do biopsy. Sperms are present, then you can pick up those sperms, you can extract those sperms and inject into the oocyte. So then you can do sperm extraction and ICSI. Sperm extraction are very weird names. Tessa, Tessie, Messa, Pessa, like this. So Tessa is testicular sperm aspiration. Tessie is testicular sperm extraction. Messa, microscopic epididymal sperm aspiration. Pessa, percutaneous epididymal sperm aspiration. Next, if FSH and LH and testosterone, everything is normal, then it is post-testicular. Then you do an ultrasound, transrectal ultrasound. And then you have to do the vasal reconstruction. If that fails, then extract the sperm and inject into the oocyte. Simple. Understood? You will get a questions from here. So, agar FSH, LH and testosterone all are low, where is the problem? Hypothalamo-pituitary, Kalaman syndrome. Agar FSH, LH are high, but testosterone levels are low, it's a testicular problem. If FSH and LH are normal and testosterone is also normal, it is post-testicular. Okay? Next comes the IUI. So IUI you all saw wiki donor. So it is same like wiki donor. So IUI can be two types. Artificial insemination husband, artificial insemination donor. So what is IUI? So first you have to wash the semen by density gradient technique, and then you take a 0.5 ml of highly motile sperms. And then what are you going to do? You're going to inject this highly motile sperms into the uterine cavity. Okay? So you wash the semen, remove the debris, remove the dead lazy sperms, take a 0.5 ml of highly motile sperms and inject into the uterine cavity. And that we call it as intrauterine insemination. Okay? So what is the most important prerequisites for IUI? At least one fallopian tube should be patent. And what is the timing for performing the IUI? So you have to do it 36 hours after the LH surge onset or after you have given injection HCG. So basically it should be coinciding with the ovulation. Okay. So where do we do IUI? Wherever you have erectile dysfunction, basically where they cannot have intercourse. So erectile dysfunction, retrograde ejaculation, penile deformities, oligospermia. Yeah, when female has mild endometriosis, retroverted uterus, vaginismus, anti-sperm antibody in the cervix, and unexplained infertility. So that's about the IUI. That's about the IUI. Now you also have something called as IVF. IVF may first you will give gonadotrophins and then you will monitor the follicles. Once the follicles have become around 18 to 20 then you retrieve those follicles. So oocyte retrieval or ovum pickup is done. And then each ovum is kept with 50,000 to 1.5 lakh sperms. That will give the embryos which we have to incubate for 48 to 72 hours. Then you can do day 3 embryo transfer. Yeah, you can do day 5 embryo transfer. Success rate of this is only 50%. Success rate of this is only 50%. Okay. So where do you do IVF? So I think you all know IVF is like little last resort. When sperm count is less than 10 million. More than 6 failed IUI. Severe endometriosis. Tuberculosis. MRKH when you want to go for surrogacy. When they have poor ovarian reserve. Less than 1. Unexplained infertility and severe tubal plaques. And when you are taking and injecting only one sperm directly into the oocyte, that is called ICSI. That's the only difference between IVF and ICSI. So IVF may, how many sperms you have kept around the ovum? 50,000 to 1.5 lakh sperms. Whereas in ICSI, what will you do? You're going to inject directly one oocyte into the ovum. That's the difference, right? So this is ICSI, where you're going to inject one sperm directly into the oocyte. And this is a secondary oocyte because it has first polar body. Okay. So that's about the infertility, guys. Next important topic we are going to discuss about menopause. So menopause means permanent cessation of menstruation for more than 1 year. Developed countries, the average age of menopause is 52, whereas developing countries, it is 47. What are the symptoms we have in menopause? Hot flushes or vasomotor symptoms, osteoporosis. The first line drug for osteoporosis is bisphosphonates. What does hot flushes or vasomotor symptoms means? Although it is like chilling cold, they'll feel suddenly hot. And this is mainly due to estrogen withdrawal and this coincides with LH surge. They are best to tell all your secrets because they'll not remember dementia. Have you ever seen any young girls getting heart attack? Absolutely no, because estrogen is cardioprotective. But in old age, there is increased risk of cardiovascular disorders, mood swings, urogenital atrophy, wrinkling of the skin. These are some of the side effects or the loss of libido. These are some of the features or clinical pictures what we have. So how do we diagnose? Hot flushes on 2 occasions 6 weeks apart. Any of the symptoms, you should have 2 occasions 6 weeks apart. Amenorrhea for more than 1 year. Only parabasal and basal cells will be 100. Intermediate and superficial cells are 0, 0. Estrogen levels have dropped down less than 20 picogram per ml. And FSH and LH will be more than 40. FSH and LH will be more than 40. Okay? Hi, Abdi Salam. Very nice you're joining the session. So, How do we treat this menopause? All this menopause is mainly due to absence of which hormone? Estrogen. So if uterus is present, you give both estrogen and progesterone. Why are you giving both estrogen and progesterone if uterus is present? If you give only estrogen, it can lead to endometrial hyperplasia and cancer. That's why you have to give estrogen and progesterone together. But if uterus is absent, you give only estrogen. So normally the estrogen what we give is conjugated equine estrogen. Progesterone you can give medroxyprogesterone acetate, norethistierone enanthate and levonorgestrel IUCD. Hormone replacement therapy is especially indicated in hot flushes, osteoporosis and urogenital atrophy. And hormone replacement therapy is not indicated. This is important point, guys. Hormone replacement therapy is not indicated for primary prevention of coronary artery disease. Okay. So 48-year-old female suffering from severe menorrhagia underwent hysterectomy. She wishes to take hormone replacement therapy. Physical examination and breast are normal, but X-ray shows osteoporosis. What is the treatment of choice which you want to give for her? Actually, for osteoporosis, best is bisphosphonates, but now we don't have bisphosphonates here. So what is the treatment of choice which you want to give her? As uterus is present. No, she underwent hysterectomy and uterus is removed. So as uterus is removed, you will give only estrogen. Very good. The answer here is C, estrogen alone. Right? So there are certain complications with HRT. That is, it can lead to gallbladder disease, cholecystitis, thromboembolism, breast cancer when you use for more than 5 years, and ovarian cancer when you use it for more than 10 years. That is why you give minimum dose maximum for 5 years. That is why you give minimum dose for maximum 5 years. Okay. So the next topic what I want to discuss is endometriosis. So guys, are you able to retain what I'm discussing? Is it going inside your head? Right? So endometriosis is presence of functioning endometrium outside the uterus. है ना? So the most common site, it will first go to the ovary. So most common site is ovary and chocolate cyst. Second most common site is pouch of Douglas. Most common extra pelvic site is sigmoid colon. It will never affect spleen. So this is one video which you can definitely watch just before your exam and go and rock in your exam, right? So what is the most see why the endometrial tissue is going outside? The one of the proposed theory which is most acceptable is menstrual blood is going through the fallopian tubes outside and getting stuck there somewhere. So most acceptable theory is Sampson's retrograde flow. Sampson's retrograde flow. So what are the risk factors here? Any condition where you have repeated menstruation. So genetic predisposition is one, nulliparous, short cycles, early menarche, late menopause, didelphys, imperforate hymen, transverse vaginal septum and obesity. What will stop this? Exercise, smoking, progesterone. Because pregnancy has lot of progesterone which will stop the growth of the endometrium, and it is having so much of amenorrhea. So pregnancy is protective, guys. There are 3 clinical, this has been asked as an MCQ. What is the main symptom of endometriosis? So the symptoms of endometriosis, you can remember it as dance, India, dance. Dance, India, dance. D stands for secondary dysmenorrhea. And this secondary dysmenorrhea, they'll have progressive dysmenorrhea, or it's also called triple dysmenorrhea. She'll have pain before menstrual cycles, she'll have pain during menstrual cycle, she'll have pain after menstrual cycles. They will have infertility, and they'll have painful coitus, which is called as dyspareunia. So the triad is dysmenorrhea, infertility, dyspareunia, right? And next, coming to the clinical signs, they'll have fixed retroverted uterus, firm fixed adnexal mass, and bluish nodules in the pouch of Douglas. So here, so I have a query here that is from Clayton. What is the role of testosterone in females? So normally the testosterone will lead to the androgenic effects in the female, like, the pubic hair, axillary hair, right? And not only that, testosterone also gets converted into estrogen, and testosterone is one type of source of estrogen, right? So investigation of choice is laparoscopy. Gold standard is also laparoscopy. Early lesions will look like just a dot, petty case. Late lesion will look like powder burn appearance or matchstick head appearance. Management, the first line drugs are progesterone, whereas drug of choice are GnRH analogs, that is mainly elagolix. It's a oral GnRH antagonist. GnRH analogs means it can be both GnRH agonist as well as GnRH antagonist. Simple. This is about the endometriosis. And endometriosis, this is how the nodules will look like. See, blackish nodules. This is a chocolate cyst. When you have cyst and cyst size is less than 3 centimeters, you can just aspirate the cyst. And when you have cyst and cyst size is more than 3 centimeters, you have to do cystectomy, guys. Okay? So what is a key point you will remember in endometriosis? They'll have too much pain. And when next very important topic is fibroid. Fibroid is also called as leiomyoma or fibromyoma. This is the most common benign pelvic tumor. It is the most common solid pelvic tumor. It is both estrogen and progesterone dependent. Earlier we used to think that fibroid is only estrogen dependent. But later we found that it is both estrogen and progesterone dependent. So it is more common in nulliparous. There is a saying that the uterus which cannot bear a fetus consoles itself by bearing a fibroid. More estrogen, progesterone, so early menarche and late menopause, when they have family history, and when they have chromosomal translocation between 12 to 14, and obesity. So they can give this picture and ask you about the fibroid. A fibroid which projects outside like this is called subserosal fibroid, and this has a peduncle. So this is called as pedunculated subserosal. A fibroid which is present in the muzzle is called intramural. A fibroid which is projecting into the mucosal layer is called submucosal. So you have submucosal, intramural, and pedunculated subserosal. What do you think? Which fibroid is most common? Intramural is most common. Right? Now, next, the most common change which we see in fibroid is hyaline degeneration. And least common change what we see in fibroid is sarcomatous degeneration. Most common change what we see in the pregnancy is red degeneration. Mainly red degeneration is seen in the second trimester. So treatment will be, and they'll have pain and fever. So treatment will be symptomatic. You will never remove a fibroid. Now on the whole, what are the symptoms which fibroid present to us? Most of them are asymptomatic. But the symptoms mainly depends on the site of the fibroid. If it is a submucosal fibroid, they'll mainly present you with heavy menstrual bleeding and recurrent abortion. If it's an intramural fibroid, they will present you with congestive dysmenorrhea. Pedunculated subserosal can undergo torsion. Subserosal fibroid can cause pressure symptoms. Cervical fibroids will mainly have bladder problems. Anterior cervical will cause increased frequency of micturition. Posterior cervical and central cervical will cause retention of urine. Retention of urine. Okay? So investigation of choice is ultrasound. This is how the fibroid will look like. So it will look like a hypoechoic mass. Hypoechoic mass. Do you know what is this? So when there is a heterogeneous echo pattern, black and white, black and white. This is called adenomyosis. This is a presence of functioning endometrium in the myometrium. Functioning endometrium outside the uterus is endometriosis. Functioning endometrium in myometrium is called adenomyosis. So it is functioning so this is the adenomyotic tissue, endometrial tissue in the myometrium. So again, they'll also have severe pain and heavy bleeding. But this is more commonly seen in multiparous. Uterus will be uniform and globularly enlarged, and it will be tender uterus. This tender uterus is called Halban sign. Halban sign. So first line is ultrasound, where this appearance is called salt and pepper appearance. Investigation of choice is MRI, where junctional zone thickness, that is the junction between endometrium and myometrium, will be more than 12 mm. First line drug here is LNG IUCD, whereas definitive treatment is hysterectomy. Knock out the uterus. One more thing, so this is how the adenomyosis looks like in a cut section. Small cysts, and and myometrium will be enlarged. One more thing which can look like a fibroid is this. It's called endometrial polyp. Fibroid was black in color. Endometrial polyp will be white in color. So this is the white endometrial polyp. It will be white in color. And you can see one vessel going into this polyp. That's called feeding vessel sign positive. Feeding vessel sign positive. Okay. So normally, now going back to the fibroid management, whenever you have fibroids, normally if they're asymptomatic, you can just leave them alone. Whatever might be the size. If fibroids are asymptomatic, leave them alone. Where you have to go for surgery if the fibroids are asymptomatic? When it is pedunculated subserosal, when they have unexplained infertility, when your diagnosis is uncertain, and when you have rapidly increasing size. This is the time where you have to remove the fibroid, although they are asymptomatic. Symptomatic medical management, you can give NSAIDs for pain relief. For to decrease the bleeding, you can give combined oral contraceptive pills, progesterones and tranexamic acid. To increase the size and pain and bleeding, you can give GnRH analogs, danazol, gestrinone, mifepristone and ulipristal acetate. I repeat, GnRH analogs, danazol, gestrinone, mifepristone, ulipristal acetate. If somebody is young woman and she want to retain her uterus, and if she has a fibroid, you will remove only the fibroid. That's called myomectomy. If somebody is old but doesn't want to remove her uterus, family is complete, then you can go for uterine artery embolization. Yeah, high intensity focused ultrasound. Family complete, old, everything is over, want to remove uterus, you can go for hysterectomy. Understood? So what management when only will be asked as an MCQ, guys. So this is uterine artery embolization. And this is high intensity focused ultrasound on the fibroid. High intensity focused ultrasound on the fibroid. Okay, let's see this question. A 45-year-old nulliparous woman is being evaluated for inflammatory bowel disease as an inpatient. Ultrasound shows a 5 cm fundal fibroid and a 3 cm anterior wall fibroid. Her periods are regular, 4 to 5 days in 30 days. She denies any intermenstrual bleeding. She is up to date with smears, with normal results. What is her management? How do you want to treat her? So as she is completely asymptomatic, how do you want to treat her? So although how many ever fibroids she has, As she is completely asymptomatic, fibroid has a rule of live and let live. You live, I'll live. है ना? So as it is not causing any complaint, so you have to just reassure her. Just reassure her. Don't give her any treatment. Don't give her any treatment. Okay? Now the last thing what I want to discuss for today's session. So oncology I'm not discussing, guys. So last I want to discuss about the infections, mainly about our three main favorite infections. So this protozoa like flagellated, flagellus, undulating membrane. This is called Trichomonas. Trichomonas vaginitis is the causative organism. It is Trichomonas vaginalis. It mainly causes sexually transmitted disease. So you'll have greenish color discharge, lot of pruritus, dysuria and dyspareunia. Very classical of Trichomonas is they'll have strawberry cervix. Very important, guys. They'll have strawberry cervix. So investigation of choice is saline microscopy, where you will see the flagellated protozoa. Gold standard is culture on Diamond's media या Feinberg's Whittington media. What is the management? Drug of choice is mainly metronidazole, both in pregnancy and non-pregnant. So that's about the Trichomonas. Next we have so this is how the pap smear of Trichomonas looks like. So you know it will have a flagella and undulating membrane. Okay? Next coming to the Candida. Candidiasis is caused by Candida albicans. This is more common in immunocompromised women, diabetics, in pregnancy, when we mainly have acidic medium, because this mainly grows in the acidic medium. Here it will be curdy white discharge with lot of pruritus. When you put 10% KOH, you will see pseudohyphae. Culture is mainly on Sabroid's dextrose agar. That's the gold standard. And what is the drug of choice? Fluconazole. Next we have this is a pap smear appearance. This is called sheikh kebab appearance. So all these are the pseudohyphae and these are the vaginal epithelial cells which are wound around. Okay. Next we have bacterial vaginosis. So bacterial vaginosis is alteration of the microflora of the vagina. Alteration of the microflora of the vagina. So what is going to happen here is the good bacteria, that is lactobacillus, is going to decrease. Whereas the bad bacteria, Gardnerella, Mycoplasma, Bacteroides, Peptostreptococci, Mobilincus, Ureaplasma urealyticum, all these are going to increase. So it's the alteration of microflora. But this does not include inflammation, so there is no pruritus. It's only dirty white malodorous discharge, but there's no pruritus. Very, very, very important is the Amsel's criteria. What is Amsel's criteria? So what is Amsel's criteria is you have dirty white foul smelling discharge. pH will be more than 4.5. And when you put 10% KOH, you'll have fishy odor. That's called whiff test positive. And you will see clue cells. What are clue cells? Bacteria attached to the vaginal epithelial cells. Clue cells should be more than 20%. This is how the clue cells look like. Drug of choice here also is metronidazole. Okay. So that's about the infections. That's about the infections, right? So next we'll discuss about the prolapse. So why do we mainly see the prolapse? So prolapse is mainly due to loss of the supports. So here in prolapse, it is a displacement of the entire organ outside. So you can have urogenital prolapse and uterine prolapse. So it's mainly loss of the supports like ligaments. So it's mainly the loss of the supports like cardinal ligament or uterosacral ligament So level 1 support is cardinal and uterosacral ligament. Whenever these supports are lost, it can lead to uterine prolapse, vault prolapse, endometriosis. Vault prolapse means after the uterus is removed, the vagina which is left out is called vault. That can come out. Level 2 supports are levator ani muscle, levator fascia. So that weakens, it can lead to cystocele and rectocele. Bladder bulging into vagina is cystocele. Rectum bulging into vagina is called rectocele. Level 3 supports are urogenital diaphragm and perineal body. That damages, you have deficient perineum and urethrocoele. Now, mainly in prolapse, they'll ask you about what is the management for each abnormality. So I made a beautiful table to discuss what is the management for each abnormality. Now, please concentrate this and listen. If you have a young nulliparous woman, then you do sling surgery for her. Young nulliparous who want to preserve her uterus, sling surgeries. Multiparous, but young, family complete, but reproductive age group like 30 to 40 years. Then you can do Fothergill's operation. I repeat, guys, if you have young who want to preserve the uterus, do sling surgeries. If you have multiparous lady, family complete, but young reproductive age group 30 to 40 years, do Fothergill's. Fothergill's is also called as Manchester's operation. So what is Manchester's operation? So Manchester's is where you have the first you will do DNC, first preliminary DNC, followed by you're going to evacuate the entire you're going to amputate the cervix, and then you remove the cardinal ligaments from either side of the cervix and tie it in front of the cervix. That will pull the uterus and cervix back. So first do DNC, then cut the cervix, then remove the transverse cervical ligament and tie it in front. Then you do anterior colporrhaphy and posterior colpoperineopathy. Multiparous lady, family complete, then you do vaginal hysterectomy, elderly. Extremely elderly, who is unfit for any major surgery. First you try pessary. If that didn't work out, then you will go for Leafold's colpoclesis. So Leafold's colpoclesis is where you obliterate the anterior and posterior. You push the entire uterus inside and you obliterate the anterior and posterior part of the vaginal wall. For rectocele, we do posterior colpoperineopathy. So vault prolapse. After the uterus is removed, the vagina which is left out is called vault prolapse. So vault prolapse, the best surgery is sacrocolpopexy. That is, you are fixing the vault to the sacral promontory. Or the alternative to that is sacrospinous fixation. For enterocele, you tie the uterosacrals to the vault. So we have Macal's sculdoplasty, we have Halban's repair, Moskowitz surgery. Remember the names of this. Enterocele, what is the surgery names, guys? Enterocele, Macal's sculdoplasty, Halban's repair, Moskowitz surgery. Cystocele, anterior colporrhaphy. Nothing can come beyond these names of the surgeries, you know. So I repeat again, guys. Young nulliparous sling surgeries. Multiparous young but family complete Fothergill's Manchester's. Multiparous elderly family complete vaginal hysterectomy. Elderly who is unfit for major surgeries, pessary followed by Leafold's. Rectocele posterior colpoperineopathy. Vault prolapse sacrocolpopexy followed by sacrospinous fixation. Enterocele, what are the surgeries? Macal's sculdoplasty, Halban's repair, Moskowitz surgery. Cystocele, anterior colporrhaphy. So what are the sling surgeries we have for young nulliparous women? So Purandare cervicopexy, where you are tying the cervix to the posterior aspect of rectus sheath. Shirodkar sling surgery, where you are tying the posterior aspect of the cervix to sacral promontory. Khanna's, where you tie the lateral aspect of the cervix to anterior superior iliac spine. Virkud is a very smart person. He does two things. Left-sided Purandare, right-sided Shirodkar. Left-sided Purandare, right-sided Shirodkar. So both of them together is Virkud. That's about the prolapse. So this is how the pessary looks like. Old women you can put, or pregnancy ladies you can put. Okay? Next comes the fistula. The most common fistula what we have is vesico-vaginal. That is the connection between the bladder and vagina. How do we differentiate between these fistula? Mainly it is by 3 swab test, guys. 3 swab test. So normally remember, guys, when you have a connection between the ureter and vagina, that is called as uretrovaginal fistula. Uretrovaginal fistula. So here what happens is urine through this ureter will be continuously coming out. So you'll have continuous urine dribbling and but normal micturition is also there because urine from another ureter is coming into the bladder. Vesico-vaginal fistula mein, there's no urine coming into the bladder. It's only the urine coming out through the vagina. So they have only continuous urine dribbling from the vagina, no normal micturition. Uretrovaginal mein, it is the urine coming out from the urethra through vagina only during micturition. So uretrovaginal में continuous passage of urine plus normal micturition. Vesico-vaginal में continuous dribbling of urine plus no normal micturition. Uretrovaginal में passage of urine only during micturition. Urine from vagina only during micturition. How do we differentiate between these three? 3 swab test. If upper swab is wet by urine but not by blue color, then it is uretrovaginal fistula. If middle swab is wet by blue color, then vesico-vaginal. Lower swab is wet by blue color, uretrovaginal fistula. Now most common is vesico-vaginal. So how do we, some points about vesico-vaginal. You know, I see this is how the revision should be. It's not like you'll go hours together reading same thing again and again. Taka atak, pin to pin, print in your brain and close the book and enjoy. So if you are able to concentrate for the 2 hours and finish this gynec, whatever I've taught you and retain in your brain, you can rock in the exam because we have completed all the topics of gynec which are important in a quick rapid revision in this 2 hours, except oncology. So oncology has to be read. Yes, apart from that, I've discussed everything. So most common is vesico-vaginal fistula. Most common cause of VVF in India is obstructed labor. Most common cause of VVF in developed countries is post-hysterectomy. So vesico-vaginal fistula, the investigation of choice is mainly cystoscopy. So you have something called as 3-layer technique or Lascaux technique. What is the surgery for it? So timing of repair. If you have detected this within 24 hours, repair immediately. You have detected after 24 hours, repair after 6 months. Sorry, 6 weeks, 6 weeks. If it is a radiation fistula, you repair it after 12 months. You repair it after 12 months. Okay. So that's about the timing. After fistula repair, continuous bladder drainage for 2 weeks. No coitus for 3 months. No pregnancy for 1 year. So I remember it as 1, 2, 3, but you know it is not matching like which one is 1, 2, 3. So there is something related to 1, 2, 3 here, right? So that finishes the entire gynec, a quick rapid revision. I hope you all enjoyed the session and it was useful for all of you. Thank you so much for your patient listening. Thank you so much. And yes, I am Dr. Ramya. You can follow me on my Instagram profile, that is Dr. Ramyasri7, to ask me all your queries. I'm just one message away. And you can also join my Telegram group, which is Dr. Ramyasri Obgyn Pack. Thank you so much, guys.